Perfect.
Okay.
Thank you everyone for joining us today. So my name's Rosie Robinson. I'm a clinical lead specialist radiographer at James Cook University Hospital in Middlesbrough. So my role in the department is predominantly working within the treatment pathway for cancer patients undergoing radiotherapy treatment. And I'm based on what we call the treatment floor, so the treatment rooms where we deliver the treatment. We operate the machines and help support patients manage any side effects whilst they're going through treatment. I'm joined by Jo and Jo, so I'll hand over to them to introduce themselves as well.
Hi, my name's Jo Small, and I'm also a clinical specialist therapeutic radiographer, and I am based at the Northern Centre for Cancer Care in Newcastle. I work clinically, also on the treatment floor. I am also a practice educator and work alongside the students and apprentices within the department, so looking at pre-reg education for them. Over to you, Jo.
Afternoon all, I'm Jo. I'm part of the radiotherapy physics team. So we use our scientific knowledge to keep the high energy X-ray machines and devices that are used in radiotherapy safe and effective for the patients.
So today we're going to have a bit of an introductory session on radiotherapy treatment, so covering what it is, how it works, the different modalities that are available to us in our departments, and then this should hopefully set us up nicely to have our second webinar, which is going to be in November, which is going to surround sort of the patient pathway, including the pre-treatment CT side of things, the radiotherapy planning and the actual treatment delivery. So just a bit of sort of setting the scene today with what's involved in our jobs and in our departments. Just the next slide, please, Katie. Thank you. So starting with what is radiotherapy. So radiotherapy uses high energy X-rays to destroy cancer cells. The aim of the treatment is to treat the cancer, the tumour, without causing damage to the surrounding normal tissues and organs. And you'll find out in this webinar and in the next, there's lots of steps that we put in place when delivering radiotherapy treatment to minimise any potential damage that could be caused to these normal surrounding organs and tissues. And in turn, that helps keep patient-related side effects, both acute toxicities and late effects, down to a minimum as well. So patients are prescribed a dose of treatment, which is measured in grey, and this dose is split into what we call fractions. So if you ever hear people referring to the word fractions, that is purely just the amount of treatments that a patient will have. And the dose and fractionation prescribed to the patient is dictated by the tumour and the area that we're treating within the body, and there's national guidance on sort of these dose and fractionations, which is from the Royal College of Radiologists, and that is accessible online. And then things like clinical trials obviously inform what dose and fractionations become national standards essentially. Treatment is typically delivered 5 days per week over several weeks. Depending on where we are treating in the body, some patients will have much longer regimes of treatment, potentially up to 7 weeks of treatment. Other patients might even have as little as 1 treatment, just depending on the intent of what we're delivering and where we're treating in the body. And treatment is delivered by a team of therapeutic radiographers, so like myself and Jo. Around half of all cancer patients will receive radiotherapy as part of their pathway at some point in their pathway. Just the next slide, please, Katie. So moving on to treatment intent. So treatment is delivered with either a radical or a palliative intent. For those on a radical pathway, treatment can be used as the main or standalone primary treatment. So an example of this would be a patient undergoing radical prostate radiotherapy alone, if they've not had prostatectomy. You know, that is one of our most common sites that we deliver as primary treatment in the department. Treatments can be adjuvant, so given additionally to the primary treatment to improve disease control, for example, following surgery. So an example of this could be many of our breast cancer patients who will undergo mastectomy or wide local excision and then have radiotherapy adjuvantly afterwards to improve their disease-free survival. And that's become sort of a gold standard treatment for breast patients. There's neoadjuvant treatment, which is given prior to the primary treatment to shrink tumour. So in the case of, say, colorectal cancers that might be due for surgery, we might give radiotherapy to shrink the tumour down to make it more excisable. And then some patients have combined chemoradio regimes either concurrently or sequentially, obviously being at the same time or in sequence. Palliative treatment is used for symptom relief, i.e. pain control, to control bleeding caused by certain tumours, or to slow down growth of disease. And we also treat emergency spinal cord compressions with radiotherapy as well, often because a tumour within the vertebra is encroaching on the spinal cord and can cause loss of sensation in the legs or the arms and loss of control of bladder or bowel. So we can give emergency radiotherapy to aid with spinal cord compressions and minimise development of those side effects of the disease as well. Next slide, please, Katie. Thank you. So then treatment modalities. So radiotherapy can be delivered either internally, so if you've ever heard the term brachytherapy, or more commonly using external beam radiation. So the majority of what we will go on to discuss is in relation to external beam radiotherapy. So brachytherapy is where a radioactive source is placed into the body. For example, we can treat the cervix or vaginal vault brachytherapy. Some centres embed prostate seeds into the prostate that are radioactive, or place radioactive sources, say, into the esophageal lumen in the case of esophagus cancer. But the majority of patients having radiotherapy will actually receive external beam radiotherapy, which can either be delivered via photons, so that's the type of particle that we use to treat, and that's the most common modality that we use in our departments that our machines are equipped to deliver. There's also options such as protons, which you may have heard sort of in the news, or as being a more newly accessible treatment in the United Kingdom, and that's typically used to treat the brain, the spinal cord, and the head and neck. Or there's also electrons as well, and we do have electron treatment in our centres to treat superficial lesions, so areas that are close to the skin surface is where we would be best suited for electron treatment. Next slide, please. And I think I'm handing over to Jo now.
Thank you. So to deliver radiotherapy, we use machines called linear accelerators, which are specific to radiotherapy departments and are only used by therapeutic radiographers to deliver treatment. They allow us capability of delivering treatment to millimetre accuracy, and a lot of our processes are designed to ensure that we have reproducible patient position, to ensure that we've got a stable treatment position to deliver that dose as accurately as possible. We have to be really considerate of the design of the rooms for these machines because of the high energy x-rays that we are using. So they are housed in lead-lined bunkers to protect the staff from any kind of radiation exposure. And these are called bunkers within the department. The machines have also the capability of taking x-ray images so that we can visualize where we're treating to ensure that, again, the accuracy is as pinpoint as possible. And we can do this using 2D x-rays or with a 3D CT image as well. The machine has the capabilities of moving around the patient in 360 degrees. The bed is also able to move so that we can really be accessible to all tumours to deliver the treatment as safely as possible. Within the head of the machine where the x-rays come out, we are able to collimate the beam to different shapes using the multi-leaf collimators. And this has been a huge advance within radiotherapy, which has really evolved a lot of our practice, so that we can really tailor the dose to a high tumour dose while sparing the tissues around it. There are other technology within radiotherapy which we don't utilise in the Northeast. Things like gamma knife machines, MR Linacs are an emerging technology within the radiotherapy field, which combines an MR scanner with a Linac, which allows the provision of scanning, planning and treatment in all one unit. I think the patient pathway is going to be discussed in one of the follow-up sessions, so I don't want to go into too much in this presentation. And one of the further advances as adaptive radiotherapy, where we're actually responding to changes within the patient, whether that's contour or tumour response, in real time, and making alterations for that plan so that it's, again, the accuracy is as best that we can achieve. Can I have the next slide, please? We are governed and driven by technology, and the advances over the last couple of decades have been absolutely massive in our field. As I've already said, the collimation of the beam, when I first started, we were still using kind of square fields where we had to shield corners with lead blocks. So actually being able to do that within the machine head has really altered our practice and made us think about how we can do things differently. Which seen the introduction of intensity modulated radiotherapy, where the intensity of the plan and the beam can be altered as we deliver the beams, so that we're targeting the tumours to a really high dose, protecting the tissues around it. Alongside this, the introduction of routine image-guided radiotherapy, where we take images to check that we're in the right position, and the advancement within that area from 2D to 3D online imaging has really driven us forward, because we can say for certain that we are within the right area when we're delivering these high doses of treatment. Further on from that, we've been able to deliver these treatments within arcs. So historically, they were standalone static fields. However, actually delivering in an arc has made us use the MLCs further, and it means that we can further contour and deliver higher doses to our patients, which is forwarded on to changes in practice and the introductions of new techniques and treatment regimes called SABR, or stereotactic ablative radiotherapy, which has allowed us to utilise the accuracy of the contouring of the fields and the change in intensity of the beams to deliver really high doses of radiotherapy over shorter periods of time, so reducing the treatment times for the patients and the number of visits they need to make to the hospital. Stereotactic radiosurgery is the delivery of really, really small beams, and these can be used for benign as well as malignant tumours. And it's a non-invasive technique, so the patients don't need to be hospitalised. So there's a real benefit to both the department and the patient as well. We were always thinking about the problems that we face within radiotherapy, and unfortunately, as we all know, a lot of the internal anatomy moves around while we are monitoring the tumour. So we have to be really careful that we are keeping an eye on and tracking where the tumour actually is during the treatment as well, so that we don't miss it because of involuntary motion. And finally, surface-guided radiotherapy allows us to track the motion of the patient's skin and body surface, again, trying to increase our accuracy and improve our patient pathways as well. Next slide, please. So as much as we consider all of the technical sides of things to improve our practice and drive that forward, we still have to pay attention and be involved in clinical trials, making sure that we are delivering the best standard of care to our patients, whether that's looking at doses that we're delivering or the impact of dose on side effects and how we can manage them better by altering the doses, changing the treatment plans, and utilising the technology that we actually have in front of us. It might also be looking at long-term and short-term side effects as well. And across the network in the Northeast, we have dedicated clinical trials teams and are participating in major clinical trials, which really changed the face of radiotherapy practice. And I'm going to hand you over to Joe now.
Great. So that's our introduction to radiotherapy, what it is and where it fits in. I'm going to now talk about how radiotherapy actually works and then how we are delivering it in practice. So if anyone had any questions about that before we moved on to that, now's a great time for it. Otherwise, could I have the next slide? Oh, sorry, I realised someone's got a question.
Yeah, I think we've got a hand.
Yeah, hello. Do you want me to put my camera on or?
Yeah, that'd be great, and then we can just
Yeah.
see who you are.
Hello, thank you very much. Yeah, I was just hoping to have a bit more detail around clinical trials. If there was anything else that you could share around that. I'm particularly interested in equity around clinical trials and addressing all underrepresented groups.
So as Joe mentioned, we've got in each of our centres, we do have a dedicated clinical trials team. I'm not so sure about at Newcastle, Joe, but at Middlesbrough, our radiotherapy dedicated clinical trials team are actually all ex-radiographers, therapeutic radiographers by background, so they've really got a hand in the awareness of what's involved with the patients that come through to us, and they're namely responsible, obviously, for the consent process, for sourcing the patients that are appropriate for the various different trials that we've got on, and then the regular follow-up that they get that might be more in depth than potentially, say, a patient who's not involved in these clinical trials. So is there anything particularly you wanted to know, or for a certain particular area? We do have a couple of major trials on at the moment at James Cook, so things like the PACE Nose, the Stampede 2, which is a very high recruiting trials. But is there any sites in particular, or
I was
Yeah,
just going to jump in there, Nusrat. It's Casey.
Oh, yeah.
Hi.
Hi, Casey.
Hi, I'm the Northern Radiotherapy Network Manager, and we have a programme of work to look at increasing recruitment to clinical trials, and one of those work streams currently is around improving equity of access to trials, and we're doing quite a lot of work to raise the profile of clinical trials, as you know, in the network and beyond.
Yeah. Thank you for that, Katie. And just to answer the other lady's question, so thanks for sharing details of those two trials. So I'll look at those, and then if I've got any very specific questions, I can follow up on those individually. Thank you very much.
Our speakers will put in their email addresses at the end of this presentation into the chat. So if anybody has got any direct questions to any of the speakers today, they can contact them via email as well, which I think is often quite helpful. So thanks, Joe, over to you.
Great. So to build out the context of the radiotherapy, this is ubiquitous across the country. There are approximately 60 UK centres delivering radiotherapy, and that's driven by the clinical need for it, in that approximately 1 in 2 people will be diagnosed with cancer at some time in their life, and it's approximately a quarter of the causes of death in the UK. But the thing I'm going to emphasise is that cancer survival has essentially doubled over the last 40 years, and one component of that improvement has been the improved delivery of treatments, for instance, radiotherapy, which I'll now discuss. Next slide, please. But to really ground us in what we're doing here, as was mentioned earlier, this picture kind of encapsulates the nature of radiotherapy. What we're envisaging is using ionizing radiation in its many forms, but in particular X-rays, to cause damage to cells, and in particular ability to reproduce via damage to the DNA. And so that's the core picture. That's how the mode of action. Next slide, please. So perhaps in eras gone by, this is the picture of what radiation might do to you, but in more precise scientific terms. Next slide, please. This is what's happening. So we have our strand of DNA, and we have the ionizing radiation come in. And ionizing means effectively that it will cause damage. And this can take different patterns. So on the picture on the right, you can see DNA strands with what are called single strand breaks. And this typically is a more kind of glancing blow by a particle that quickly exits the area. But we also have double strand breaks, typically by particles that are heavier and slower and less likely to leave the vicinity. And that is more damaging. But both varieties of damage impinge the ability of the cell to successfully reproduce. And that's what we're using ionizing radiation for. That's why we need it. Next slide, please. But how does this work? We can cause damage to the cancerous cell, but how is that causing or hopefully leading to a cure? And in effect, for most tumours and most normal tissues, what we see is the preferential ability of the normal tissue to repair to any damage. So in this graph here on the x-axis, we have the incident dose, and then on the y-axis, we have the probability of recovery. And we can see that essentially there's a window of opportunity where if we get our dosage correct, we cause minimal damage to normal tissue, the healthy tissue, with maximum damage to the tumour. And that's why we need that kind of millimetre level precision, that high degree of accuracy in radiotherapy to ensure that we're in that sweet spot. And that's why technology has been able to help us so much. Next slide, please.
Mhm.
We utilise that effect that the normal tissue is better able to repair by fractionating our radiotherapy. So that was discussed earlier, but I just wanted to give you a picture of what's going on across a course of treatment. So we break the treatment down into discrete fractions, and what we're seeing is a kind of differential increase in the difference between the population of tumour cells there at the bottom versus the normal healthy cells. And by basically spacing it out over a treatment, we get the maximum possible benefit from that kind of different, what's called radiobiology. And then hopefully that picture on the right encapsulates what happens afterwards, with the kind of the tumour being non-viable and the patient recovering from the radiotherapy. Next slide, please. That kind of establishes the basis for why we need ionising radiation and how we deploy it. I just wondered if anyone had any questions.
Joe, I was just going to jump in there because we did have a couple of messages in the chat about why treatment's delivered over 5 rather than 7 days. I wonder if you could just expand on that in terms of the sort of recovery of the healthy cells.
So the specifics for a particular clinical site will depend on how that tissue grows. And so I kind of obviously represented a normal tissue, but there's obviously a wide variety across the body. You know, prostate healthy tissue will grow slower than other tissues. And so basically we're choosing a fractionation that suits the specific tissue under consideration. And so that's why we need different fractionations for different sites. It will be different basically depending on what tissue is being irradiated. I've simplified that, but.
And is that just in terms of sort of why you treat for 5 days and then a patient has a break? That's to do
I see, about the weekend. I would say that's a largely historical thing. That's how that's how radiotherapy is delivered. It's largely an outpatient service, and so treatments haven't been offered at the weekend. And then that space to recover for the patient is built into the fractionations that we deliver. So it's not fundamental in some sense that they're not treated at weekends, and very occasionally we will do that if the patient specifically needs a kind of accelerated level of treatment. But it's something that we've kind of like adjusted our dosages to give the patients a weekend to kind of recover from the ionising damage to their healthy tissue.
Great, thanks.
So moving now to discuss how we actually deliver radiotherapy, and like Rosie and Joanne introduced in their talk, there are different approaches to delivering the ionising radiation. So that I've just broadly categorised it by emission, so in unsealed kind of treatments in nuclear medicine, or using actual radioactive sources in brachytherapy. And these are pictures that might be associated with these types of treatments. What I'm going to focus on is the predominant one, which uses transmission, i.e. shines from externally to the patient an X-ray source, and gets the radiation targeted to the treatment site. Next slide, please. And all across the world, the almost totally dominant form for doing this is something called a linear accelerator, which is often abbreviated to a LINAC. And this is a kind of a picture of what a modern day one would look like. And so in real broad brush terms, at the top there we have the part where the X-rays are produced and guided or collimated, and then to the side we have devices that help with imaging the patient, making sure they're set up correctly, and then the black thing in the middle is the patient couch where the patient is positioned. Next slide, please. So to put this further into context, obviously people will be very familiar with the really widespread use of X-rays for diagnostics, but I really wanted to kind of contrast where this sits with kind of therapy uses of X-rays. So it's a much higher energy. It's approximately 10 times higher energies that we're using to accelerate than diagnostic. So what I've got here on the right is a plot of dosage delivered with depth within a patient. And you can see how that kind of orange diagnostic type energy really rapidly tails off. So we can't get much dose deep within the patient, whereas the types of energies that we're using deliver dose more broadly across. But not only is it higher energy, it's much higher dosage. For a single fraction of radiotherapy, we're delivering, it will depend on the site, for instance, but we're delivering approximately 1,000 times higher dosage than a single head CT. And that's just for a single fraction. If we're delivering 10 or so more fractions, it'll be 10,000 times. So yeah, it's a completely different domain in terms of the energy and dosage. So I just wanted to kind of, yeah, we've got this picture up close of what a LINAC looks like, but this isn't how it will look like during treatment. If we have the next slide, it's a whir of activity. What we do is we have the LINAC move around, as was discussed earlier. And so the patient is on the couch, and we try and seek out the best possible set of angles to deliver the dosage from. So if we go to the next slide, please. That's how it would look to someone in the room, but the actual mechanics of how we're generating the radiotherapy treatment are somewhat different. Now, I'm going to really simplify how this works here, but what we've got is a kind of cut through of the LINAC, and we're starting from one end on the left-hand side, and this produces a source of electrons. And what we've got here, in essence, is a cannon. It accelerates those really kind of very not particularly energetic particles on the left-hand side really fast, almost to the speed of light, up to a big metal block on the right-hand side. And that produces X-rays, which we then collimate through the big metal assembly at the end that then go through to irradiate the patient and treat the target. So if you can want a very simplified picture of what a LINAC is, it's essentially it's a relativistic particle cannon. It accelerates those particles and produces X-rays. Next slide, please. Now, I'm not going to go through in detail what's going on in the head, but in essence, that is a lot of what have been the big advances in radiotherapy, is making it fully digital and much more programmable and customizable to specific patients. And we have big lumps of metals called MLCs and jaws for doing that collimation. And I just wanted to show you a quick video of that in action so you could maybe get a kind of a visual indication of how that works in practice. Next slide, please. And this should play. So this is a video from one of the major LINAC manufacturers showing us those MLCs in action. And so this is what they will do in treatment. They will move dynamically. So we can produce customizable kind of what we call fluences, which are essentially portals where the X-ray can produce through. We don't just use big open fields. These MLCs, they're about 9 centimeters thick, so they need to be very big to attenuate all that radiation. But we get them moving very fast so that we can kind of have as much flexibility to design the treatments as we need. And yeah, what I wanted to emphasize in this video is that the LINAC from the outside doesn't necessarily look like there's a lot going on, but inside it's doing a tremendous amount to really kind of optimize as best we possibly can, so that we irradiate as little healthy tissue as possible and focus on that healthy tissue, focus on that the cancerous target. Next slide, please. So here, I wanted to show how we can make use of that. So in having those kind of programmable elements in the head that enable us to kind of, sorry, I think there should be a video, the gantry should go around. Maybe if we just click on it. We can basically produce a kind of dosage within the patient that really kind of closely corresponds to what the doctor wants to treat. And the idea there is that we've got really kind of a high degree of flexibility in how we do this, and we can make it really patient specific. So on the right hand side, we have a kind of picture of how those MLCs are moving, and then as on the left hand side, we have what the patient would see in the room. And there's no necessary indication that everything is changing at any particular time other than the gantries going around. But I can show you what that dosage would then look like if we go to the next slide. So this is a kind of accumulation of dose through the treatment, and we get a very kind of customized amount of a picture of dose. So on the next slide, I can show you who that's meant to be. So I work at the James Cook University Hospital, and this is the erstwhile Mr. James Cook. And I can compare that particular kind of input that we wanted to generate to the dosage that we could then produce on the next slide. So this is basically what I'm trying to convey here, is that we can, the doctors will want to deliver dose to particular places, and the modern generation of machines really provides a tremendous amount of flexibility, enables us to do that really precisely. Next slide, please. I kind of gave you a very non-clinical indication of that. Obviously, doctors don't want to irradiate something in the image of James Cook. So I'm going to kind of work through a toy example here of how that might play out in practice. So next step, please. Here we have a particular tumor that we want to treat. And then if we go to the next one, please, we can place some beams that will, if we keep going, that will cover it in a very blocky way. And we get a very nice solid dose distribution, which completely encapsulates the target. However, you can see it's not very conformal. And so this, what we call, well, this orange tissue is healthy tissue that's getting irradiation because the dose distribution is very blocky. The modern approach of using different MLC shapes as the gantry goes around ends up with lots and lots of little beams that enables a lot more flexible dose distribution, this kind of curved one that irradiates a lot less of that healthy tissue. Now, the key clinical benefit there is that the patient receives less dose of the healthy tissue, and so that they suffer less radiation-induced effects, but also it potentially enables dose escalation, so we can deliver more dose to the tumor with less risk of side effects. And so I gave you the toy example here, but here's an example in clinical practice. So that old style of conformal planning produced very blocky dose distributions, and the modern style produces very customized and very conformal dose distributions, sparing healthy tissue and improving patient outcomes and opening up new avenues for treatment. And so it was mentioned earlier, but this type of treatment is called IMRT, which stands for intensity modulated radiotherapy. And this is something that over the last decade or two has started from very small kind of a period of firstly being able to get your machines to be able to deliver it, to then being able to commission it with your planning systems for delivering treatments. But we're now at large stage rollout in the NHS. So what I've got here is a graph of all the different healthcare providers that deliver radiotherapy in the UK, showing the percentage of treatments that are IMRT, which is a benchmark of quality, basically. How many treatments are you delivering that are advanced and modern? I'm not indicating which one is South Tees or Newcastle or NCC, but we're the blue bars at the far end, which is great, and a real indication that we've kind of taken that technological evolution and delivering the kind of standard of care for patients. As was mentioned earlier, these Linacs come with imaging devices, and as Joanne and Rosie mentioned, our radiotherapy is image guided now. Why do we want that? Well, we want to minimize the uncertainties so that we deliver our radiotherapy as precisely as possible. You might imagine that on the left-hand side shows how the patient's tumor might be differently positioned, and you can see that there's potential to essentially partially miss the target, and this causes all sorts of problems about potential side effects or reduction in treatment quality. But if we go to the next slide, you can see how imaging helps us. So what we've got here is kind of a screenshot from one of our imaging tools, which is called XVI, and it's a KV imaging system, and the green, so it represents that kind of newly acquired image on the day of treatment for that patient, and the pink represents the reference, what the patient was planned at, and we can see they're grossly different, and we're nowhere near where we need to be. And so this is providing the information to the radiographers on set that helps them set up patients as precisely as they possibly can. Next slide, please. So you might hear about SABRE. So this is essentially high-dose radiotherapy. And what I wanted to do in this section was go through very visually an example of radiotherapy in clinical practice, and in particular with a non-kind of ideal case. So what we've got here is a lung cancer. It's obviously that lesion in the lung there. And the key thing to see immediately is that it's moving. And that's just intrinsic. We can't stop the patient breathing during treatment, which will take on the order of a few minutes. So what we do is we get a kind of an indication of the fullest extent of the tumour's motion, and we take that as our guiding target, shown in yellow there. And then we go through to the next step, and we expand that to account for uncertainties in how the patient might be set up and how the machine might be aligned with the patient. And we end up with this red, what's called a PTV, or what I've referred to all the way through as a target. And so that's what we're going to actually treat. And then I'm going to show you very quickly how that might be treated in practice. So here we have what's called a beam's eye view. So looking down through the LINAC where it produces X-rays into a kind of projection of the patient. And we can see that red outline there is what we are opening the MLCs to focus on. And then if we go through the different slides, we have those MLC apertures at different gantry angles. We're keeping on target by moving those MLCs, and we're ensuring at all points that the fullest range of that tumour, which is encapsulated within the yellow, is targeted by the X-rays, giving us a dose distribution like this. And so you can see there's a lot of uncertainties that we've had to effectively account for in our radiotherapy treatment, but we end up with a treatment like this that will robustly and precisely deliver the dose to the required target. So we're approaching the end of this section where we've talked about how radiotherapy works within the patient and then how we actually deliver it. I just quickly wanted to introduce the idea of the next talk, which is kind of expanding it out to talk about how we actually then go and deliver it, which is involving the whole team. And so the next talk will cover pre-treatment, so how we prepare patients, the planning, the kind of getting a treatment ready, and then the actual process of delivering the treatment. So obviously it'd be great if you could attend for that, but we've got some more time now, so if anyone had any questions.
So yeah, thank you very, very much, and looking forward to the session on the 21st of November. So any questions from the floor? We've got some time if anybody wanted to raise their hands to ask any questions. We've had a couple of questions in the chat around, I guess, the logistics of the LINAC around noise and experience of patients and things. And I know you're going to talk about that in your next session, but yeah, we've had a question around how noisy is the machine? Is it in comparison to the MRI? And Joe's put an answer to that in the chat. So anybody got any questions? And feel free to ask what we always start a sentence with, you know, this might be a silly question or this might be a really easy question, because the whole idea of this session was a real introduction. I think on the basis that, you know, radiotherapy has absolutely changed radically over the last few years in particular. And when we were asked to do these sessions, unanimously people wanted to sort of start at the beginning. So if there are any, you know, really what people think are silly questions, and believe you me, there is absolutely no silly question, please feel free to ask them.
Vicky, it's Katie. I wonder whether I might just jump in. Just there are a few questions about sort of from the patient point of view, which I know that we'll talk about in the next session, but just to let people know that sort of patient experience of Cumbria radiotherapy is something, again, that we have been looking at across the network. And we have been producing a range of videos that give Obviously some of the talk today was quite technical from the physics side, but we've got a range of videos that talk patients through what happens through their patient pathway of coming into radiotherapy, all through the sort of the pre-treatment imaging, how the plans are drawn up in a very sort of straightforward, easy way to understand, and then what happens when they come for treatment. So we have videos available for each of the radiotherapy centres across the network. So that's at South Tees, Newcastle and Carlisle. And we also now have a range of tumour specific videos that go through exactly what would be involved in coming for radiotherapy for a particular tumour site, and what then side effects the patient might expect to experience through their radiotherapy treatment. So if people are interested in having a look at those as well, there's a lot of information on our network website, and I can drop some links into those as well.
Yeah, that'd be really good, Katie. Somebody's asked whether you'll be covering common side effects in your next session, Jo. Is that something that you will be doing, or do we need to perhaps put a third webinar on?
So that was in the plan, Nikki, I think, to do these 2 introductory ones, and then if there were specific things, we did have something around late effects, and there was something else that we had sort of proposed. So I think that it is on the agenda, and it is something that we can do specifically if there is a request for that.
Perfect. Thank you. Jo's got a hand up.
I think just in quick response to the common side effects is that radiotherapy is really localized. So we really only affect the area that we're treating in. So if it was a prostate patient, then we'd be looking out for side effects that were related to the prostate, rather than chemotherapy, where you get much more systemic treatment. So you're much more likely to see a widespread of side effects. So it's really specific to each patient. So without going into too much detail, that's the real difference between kind of chemotherapy and radiotherapy, is that we're really specific. And one of the most common things we still get asked from our patients is, am I going to glow green? Am I going to be able to go beside my grandchildren? And they aren't emitting radiation, they're absorbing radiation. So that's a really big take-home message, to kind of in conjunction with the side effects question.
Yeah, no, that's really helpful, Jo. Thank you.